Hi, I'm Dr. Alexandra Smith. I'm a naturopathic doctor here at Neurvana Naturopathic Medicine.
And I'm Dr. Erik Nelson, also another naturopathic doctor here at Neurvana Naturopathic Medicine.
Heavy metal chelation is where we bind metals in the body and we allow them to be excreted primarily through the urine, a little bit through the stool. And we add in what are called chelating agents, which are compounds that essentially move through the bloodstream and can bind to a 2+ charge, which most heavy metals are a 2+ charge. Once they're bound, then that is the product that moves through the kidneys and then is eventually excreted in the urine. So it's a process of adding in these chelating agents in order to get heavy metals out of the body.
Yeah, exactly. Chelation is actually a process that's happening all the time. So as you're eating natural compounds, there's quite a few natural chelators that you're going to find in your onions, your garlic, your cilantro, your cruciferous vegetables. So you're constantly having this binding and letting go of the metals, like Dr. Alex Smith said. And we basically use very specific chelating agents in a therapeutic context that have a very high affinity, which means that when they bind to heavy metals, they're going to be bound really, really tightly so that they're unlikely to just let go when we don't want them to let go. So what we actually want them to do is, like the name suggests, chelation actually means claw. So you want them to claw and chelate to the heavy metal and then not let go until they're all the way out of the bloodstream and they're out of your urine and you've peed them out. The people that we test for heavy metals, and it's very clear that heavy metals are above and beyond what would be considered a safe limit. And it's likely that those high metals are in some way related to their symptoms. So of course the symptoms, and you can maybe go through the symptoms that are pretty common to look for, but the symptoms are all very vague, which just means that they can be related to heavy metals or they might not be related to heavy metals. So the most important piece of the pie, for me at least, is to test and not guess. So if we test and it's very clear that specific heavy metals are high for a known exposure in a known person, then we have a very clear-cut therapeutic protocol for that.
Yeah, exactly. And I think there are clues in terms of when you're interviewing a patient and gathering that health history, past work exposure, age in terms of just being exposed to lead-based paints and mercury amalgams. These are things that happen in an older patient population. We no longer use mercury as a main amalgam agent for cavities or fillings, and lead paint is off the market now. And so it's uncommon to see it in a younger patient population where we'll see drastic heavy metal exposure versus an older patient population before, when those heavy metals were higher in our environments than they are today, much more likely to have that exposure. Work environment is another huge clue, right? So absolutely. Patients who work on rail yards or out in the oil patches that are exposed to these kind of agents all the time, they're way more likely to have a heavy metal exposure by breathing it in, but also contamination through the skin. Fatigue is a really common one. Skin concerns can sometimes be a factor. Sleep concerns. If there is plaque formation or atherosclerosis, cardiovascular concerns, that can sometimes be a factor. Osteoporosis or bone density concerns. There could be buildup of heavy metals. So again, something to screen for in testing. If you have the buildup, that's where this therapy is really indicated.
Yeah, there are different heavy metals, and of course those heavy metals have different effects in the body, and in fact they end up in different areas of the body, right? So mercury being a fairly common heavy metal that we're exposed to through daily diet, sometimes even the water we drink in. So mercury is fairly common even in today's day and age. It's not like you're going to be able to avoid that, but certain people will build up mercury at higher rates, meaning that when they bring it in, their body doesn't clear it out very well, and therefore it'll simply store in some capacity. And mercury often can get stored in neurological tissues. So you get neurological side effects, and therefore those are the symptoms you look for. So that could even be as vague as brain fog and difficulty with memory, or concerns with mild cognitive impairment, or different types of dementia. Or it could be peripheral neuropathy, numbness and tingling and sensations of like altered sensations at the tips of the fingers or the tips of the toes, for example. And so that would be an example of, okay, we have this symptom, we're not necessarily sure what's the cause as of right now, but if we test your heavy metals and it's very clear that your mercury is off the charts, that would be a good indication to do some chelation therapy for that person for that reason. All right. There's some other heavy metals like arsenic, which is really common in our environment, especially in the food environment and in specific well water. So depending on where you get your water, of course, that could be something that's tested directly, as you could test your water sources for arsenic levels. But more nefarious is actually through our diet, and very common healthy foods, say hemp hearts or rice or soy products, or, most foods will have minute amounts of it, but you'll see reports like consumer reports coming out saying there's quite a bit of arsenic in some protein powders that are pretty common over the counter and might be in your cupboard right now. So you wouldn't necessarily know you're getting excess amounts of these things, but when you test and it's very clear that you're off the charts, it might be worth discussing chelation therapy with your medical practitioner to see if that's right for you.
Primarily what both Dr. Nelson and myself look at is urine testing for chelation. It's really unlikely, unless you're currently being exposed to a heavy metal in high amounts, that you would ever find it in bloodstream. Because heavy metals, because they're inflammatory in nature, the body is going to try to pull that out of the bloodstream as quick as possible. So whatever we can't get rid of through the urine via proper detoxification will build up in tissues. And primarily this hangs out in adipose or fat tissue. Can sometimes hang out in the neurologic tissue, right? So into our brain or the spinal cord or things like that. Sometimes muscle and bone, but I would say adipose is the highest place that it's going to store. And that just renders it inactive out of the bloodstream, right? So it doesn't pick up on that testing until we look a little bit deeper. And so generally with chelation testing, kind of the process is that we look at urine samples before we've added a chelating agent. So just baseline, do you have exposure to any heavy metals? And then what does nutrient status look like? So we'll look at that in the urine, and then we'll add in chelating agents. There's two of them that we primarily add in. One is called DMPS that chelates mercury. One's called EDTA that chelates lead, aluminum, arsenic, cadmium, and pretty much every other heavy metal that we look at. With those two agents on board, those are going to start to pull those heavy metals from the systemic tissue, bind them really tightly, like what Dr. Nelson was talking about, and then allows your body to excrete them via the urine. So we collect the urine over 6 hours so that we can understand what is the burden, what does it look like in terms of overall exposure.
Yeah, and there's different protocols. Depending on who you ask, you might get a different answer there. But the important part is to get an assessment of before and after using a chelating agent. Is it something that's an acute exposure, like you are drinking it in your well water or you are exposing it in your diet? That will actually show up on that first test, and you'll see you'll have higher than normal levels of arsenic in your urine. And then when you use the chelating agent, that will just go up through the roof. And so usually what we're paying most attention to is the second part of the test, which is the post-provocation urine test, or the post-chelating agent urine test, that 6-hour sample. But it's not exclusively the only thing that matters, so that's an important caveat there. And of course, we're looking at normal essential metals at the same time, because these chelating agents aren't necessarily perfectly specific for a heavy metal. They will be pulling out some of those other important metals, and it's also important to get some detail about how much of that we're pulling out with that specific agent, because then it can dictate, if we want to do this safely, how are we going to do it safely? What metals do we need to make sure that we're repleting as we go through a protocol, for example, if the patient requires a protocol. And then there is actually one more chelating agent, which is called DMSA, and it's an oral chelator. The benefit to it is that it's incredibly safe. The downside to it is that it's not well absorbed. So typically it will pull out some heavy metals, but not as much as an IV therapy or an IV chelation protocol. But if people can't come in, they can't commit to doing an IV protocol, we actually want to use oral DMSA. You can use oral EDTA as well, but oral DMSA is the more common one. And that's the one we want to know if that's working, right? So we still want to do the testing using DMSA to see if that's going to be an appropriate strategy for that person. So we have a patient that might be coming from out of town, they're flying in, they might be doing the testing. We want to use an appropriate test and a chelating agent that can line up with what they might get as a therapy. And so that would be the time frame that I would use DMSA. And it's also very safe. So some people, they might not be good candidates for an IV therapy in general.
Yeah.
And DMSA just ends up being a easier option or safer option.
It's a safer option. It's much easier on the kidneys in terms of all of those heavy metals moving through that excretion pathway.
Mostly for lead. Mostly for lead, mercury, not
lead,
quite as good for arsenic, I believe.
Yeah, but still effective. DMSA still chelates arsenic. It's just that overall, when you take a capsule of DMSA, 33% of that is actually being absorbed into the bloodstream, which is much lower than when we use intravenous agents where we know 100% is going into the bloodstream. And so you are going to pull a smaller amount of heavy metals. It might take you longer to move through a chelation protocol, but it is safer in terms of overall kidney function and that kind of stuff. And so that's another piece of kind of our testing, is that we do look at kidney function and liver function and electrolyte balance in the bloodstream so that we can understand, is this person a candidate for this therapy, right? And if not, then oral chelation is a really safe and effective way to do that. Might take us longer, but that's okay. If you have an allergy to one of the chelating agents, then you are not a candidate for that chelating agent. You may be a candidate for others, but that's something that we do screen for before starting chelation therapy. Poor kidney function is the biggest contraindication to treatment, because we're relying on the kidneys to be able to excrete all of these heavy metals. So if the kidneys are not functioning appropriately, the glomerular filtration rate, or EGFR, that we look at on lab work, if that is not adequate, then mobilizing heavy metals that you're not able to get rid of is not a good idea. So that would be a contraindication to treatment. Yeah, I would echo that, kidney function being the primary screen. And then my other one would be pragmatic, in the sense that if you can't commit to doing the protocol, I don't even want you really starting the protocol, because you don't want to start halfway, mobilize a bunch of heavy metals, cause problems, not be able to continue with it. So that's another caveat. And then, of course, there's costs. So if you were to come in and you have to do IV therapy related chelation, you have to understand ahead of time, here's my time commitment, here's my financial commitment, here's when we're going to retesting. We may or may not have to continue with therapy afterwards. So that's a really important contraindication, which is obviously not really medical related, but it's more life related. And I think that's a really important caveat to say, because often this is done outside of the conventional medical model, which means there's a time component and a financial component to it. Right? Absolutely. And there might be better options, right? So depending on the person, depending on the time, we might just delay, right? So we might just be like, this is a great therapy for you, but not right now. We're going to do it in 6 months or 12 months, or you're going to come back and we're going to retest this in 2 years. Who knows, right? So there's going to be other caveats there. Very patient dependent. And this is monitored through regular testing, right, throughout the protocols. Average, I would say, anywhere from 12 weeks to 6 months. But usually after a 12-week protocol, we will retest the heavy metal burden. And if levels have drastically dropped and we don't need to continue with chelation therapy, we then stop. If levels haven't dropped enough, then we are going to continue with chelation therapy. One thing that I do often see, it's not always with every patient, but sometimes after a 12-week protocol, the levels actually go up on testing. I don't know if you've seen this, Dr. Nelson, but reason being is that as we pull from more and more systemic tissue, the more effective we're being with our treatment, the more we can increase that excretion of the heavy metals. So it's not a bad thing to see that the levels have gone up. It just means that there was more of a burden than what we knew originally.
And you don't want to stop.
Exactly.
That's the really important part.
We don't want to stop because the protocol is working if we're seeing that there is more coming out in the urine. So that's the key thing, is not to stop. You want to keep going, but we want those levels to come back into normal limits. And I would say that is, anywhere between that 12 week to 6 month. For oral protocols where we're using oral DMSA, takes a bit longer, could be 6 months to a year that you're on chelation.
Yeah, I'd still check at 12 weeks for sure, regardless.
Absolutely.
Yeah. Because some people it doesn't take long. And that's, you don't need to keep doing a therapy if you've already reached your goal. So it's really important to retest. And I'd say like most of the clinical trials, it's looking at closer to like 40 therapies, 40 IVs. And you're like, that could take, depending on the person's willingness to come in and how often they can come in and the rest of their life, that could easily take 6 months.
Totally.
And they don't really test, like, you don't necessarily, those protocols aren't testing along the way to see where the therapeutic benefit has taken place. But in clinical practice, that's what you do.
Yeah.
And so you're just going to, low threshold for testing, you're already on the chelating protocol. Let's do another test. Let's collect your urine. Let's just keep going. And then if we need to adjust it, we will. Maybe we need to adjust the chelating agent.
Totally.
Maybe it's not working and we need to figure out why that's not working in some other capacity. But it's really important not to stop if it's super high. Because if you are mobilizing the heavy metals, you're clawing them out of a cell, you put them into a bloodstream, and then they just float around your bloodstream causing havoc. That's the last thing we want. We really want to pull them out so that we can get them out, and not just pull them out so they can cause problems and then get reabsorbed and go back into a cell. So,
exactly.
yeah.